I'm thrilled to be here to talk about anticoagulation and triple therapy. I am a vascular medicine specialist, so I deal with anticoagulants and antiplatelets every day in my practice. And I have no disclosures. And here are the learning objectives for the talk. And we're going to follow this outline. We're going to talk briefly about the coagulation cascade because we just have to. I know that's not everybody's favorite. And then we're going to talk about anticoagulation during revascularization, anticoagulation and platelets. And then we're dividing into pre-procedural, intra-procedural, and post-procedural. So starting with anticoagulation, this is a very simplified version of the anticoagulation cascade. I'm sorry, of the coagulation cascade. And the reason why I like it is to remind all of us, okay, here are the antiplatelets, and they're going to be acting on different receptors. Remember that the platelets cover with receptors that will activate the platelets, so blocking them will decrease the activation. Remember that also that where the anticoagulants act, these are our IV anticoagulants or parenteral anticoagulants with fondaparinux, low molecular weight heparin, and unfractionated heparin acting at the level of the antithrombin, and bivalirudin and argatroban acting directly over thrombin. And our oral anticoagulants are in orange, and we have a direct thrombin inhibitor, anti-10A inhibitors, and vitamin K that works on all the vitamin K antagonist on the vitamin K dependent proteins. So let's start with anticoagulation during revascularization. You will have all these tables in your syllabus, so I'm not going to go over all the dosing, but this is to remind you that we can use unfractionated heparin, enoxaparin, bivalirudin, or argatroban during PCI. Argatroban and bivalirudin can be used in patients with heparin-induced thrombocytopenia. Remember that argatroban is contraindicated in patients with liver failure, and bivalirudin we use with caution in patients with renal failure, but we can use it. It just be requiring a lower dose. Switching between anticoagulants, if we switch between low molecular weight heparin and unfractionated heparin, it's not recommended because it increases your risk of bleeding. And fondaparinux, although it's a good parenteral anticoagulant, it's not recommended for PCI due to the risk of catheter thrombosis. In patients that were treated with fibrinolytics for an STEMI, they need to receive anticoagulation for at least 48 hours and preferably throughout the hospitalization. And the agents that we can use after fibrinolytics, we can use unfractionated heparin, we can use low molecular weight heparin, and here we can use fondaparinux, which is parenteral, and as we're not using catheters, it will not be a problem in terms of the risk of thrombosis. For the dosing of anticoagulants after thrombolytics, you also have a table in your syllabus, but we adjust the dose of enoxaparin based on the age and the renal function. And for fondaparinux, there's also adjustment for renal function. Bivalirudin, we prefer to use it for heparin-induced thrombocytopenia. Patients that have PCI after fibrinolytics, they also need to be on anticoagulation. And remember again that fondaparinux is not adequate for PCI. For unfractionated heparin, we'll gauge the dose based on your ACT. And for enoxaparin, we will dose it depending on when was the last dose of the medication to transition to the PCI. 2 words on heparin-induced thrombocytopenia. This is a problem that you will encounter in your practice. It's thrombocytopenia because of platelet activation. So remember that although the platelets are low, the patient are in a very prothrombotic state. Patients have antibodies against antiplatelet factor 4 and heparin. It's uncommon. And we typically see it between 5 and 10 days after the first administration of the heparin or low molecular weight heparin. It can happen with any of the two. But we can have rapid onset if the patients have been exposed to heparin in the past within the first 3 months, or we can have delayed onset after 3 weeks. So keep it in mind if you have a patient that develops acute thrombocytopenia and was recently exposed to heparin. We suspect it also when there's arterial thrombosis. And if you suspect it, you need to stop all exposure to heparin. So stop all heparin, even flashes, and you need to start on a direct thrombin inhibitor such as bivalirudin or argatroban. Those are IV. And test for heparin antibodies against heparin and platelet factor 4. Then after the procedure, if the heparin platelet factor 4 is negative, then you can resume heparin. If it's positive, you're going to continue with the DTI. You're going to send for an SRA or a platelet activation test, which is the confirmatory test. And you can start back on warfarin after the platelets are above 150,000. There's some data coming up on use of DOACs. Still the standard is warfarin, and we anticoagulate for 6 months, regardless of whether they had a clot or not. So anticoagulants and antiplatelets is the main topic of the core of my talk. We're going to start with a brief case. This is a 76-year-old male with an NSTEMI, and he had a PE and DVT that was diagnosed 60 days prior after a long car ride. You can see the thrombus here in one of the pulmonary arteries. His past medical history has diabetes, hypertension, he's a smoker and has GERD, had a stent 4 years before. He's hemodynamically stable. He's anticoagulated on dabigatran, 150 milligrams twice a day because of the PE and the DVT, and has slightly low hemoglobin, normal platelets, and a creatinine of 1.6. When would you proceed with cardiac catheterization? After inserting an IVC filter and reversing the anticoagulant, right away if radial access can be used, after 2 days of anticoagulation if the PT and APDT normalize, after 4 days off anticoagulation, or right away after administering PCC. Okay, and most of you choose to do it right away if we can use a radial access, and that will be fine. If we need to do it, there's an urgency to do it, but also remember that if it's this elective, we can wait after the 4 days after the patient is off anticoagulation. As it is not a STEMI, we don't need to rush. That would be perfectly reasonable if you need to take the patient urgently to the OR. So use the clinical judgment whether radial access, despite being on anticoagulation, will still have some bleeding risk. If we can wait until the effects of the anticoagulant wears off, that would be preferable in terms of reducing complications. But of course, remember that for urgent procedures, using a radial access that will allow us to do it despite anticoagulation without needing to think about reversal or discontinuation. And in terms of antiplatelets, this is just to refresh the guidelines, and you recently reviewed that. We do dual antiplatelet therapy initially, but patients that are on anticoagulation either because of atrial fibrillation or because they have a venous thromboembolism or other reasons such as mechanical valves, we have to duplicate. They will be on antiplatelet therapy, they will be on anticoagulants, and we will be blocking 2 mechanisms of hemostasis in the patient. And we have multiple clinical trials and meta-analysis that show that if you have a patient on triple therapy, your risk of bleeding is significantly higher than if you have a patient in dual anticoagulation therapy. So we have to keep a balance between the risk of bleeding and the risk of an event. And factors in the patient that will increase the risk of bleeding include comorbidities, age, and, as you know, other concomitant medications such as steroids or NSAIDs. Factors that increase your ischemic risk will be also increasing or advanced age, the type of presentation, acute coronary syndrome will increase your risk of ischemia, extensive disease, diabetes, kidney disease. And also there's factors that are specific for the stent thrombotic risk, and they're more related to the anatomy, to the history of stent thrombosis, multiple stents, location of the stents, etc. As you can see, there's a lot of factors that increase your bleeding risk and increase your thrombotic risk that are the same. So there's a group of patients that we all know who they are, that have a very high risk of developing both thrombotic and bleeding complications, and we need to be very mindful of that. So now we're going to focus on the use of both antiplatelets and anticoagulants, starting by pre-procedural. Before the procedure, we have to take into consideration what's the timing, how soon we need to take the patient to the cath lab, and also what are our possibilities and our options in terms of access. And also keep in mind, what are the indications of anticoagulation? How long has the patient been on it? What's the dose? What's the agent? Because those things are going to help us decide what are we going to do about it. We have patients that have a stable risk or they need a stable intensity of anticoagulation, and those are patients with atrial fibrillation, mechanical valve, and peripheral bypass. And with that, I mean that no matter where we're taking them in the history, the risk is pretty consistent. And that's in opposed to VTEs, venous thromboembolism, will have a much higher risk of a recurrent event if you have to discontinue anticoagulation early on. The first month is critical, but once we are beyond the first 3 months, the risk of recurrence goes significantly down. So there's a lot of patients that don't need to be on a high dose or a therapeutic dose of anticoagulants, and our risk of recurrence with an interruption will be lower. And we'll talk about that in a little more detail once we talk what to do afterwards. So if the patient needs an elective or non-emergent procedure, we can think about discontinue anticoagulation. If it's a DOAC, we're going to stop it for 24 hours for rivaroxaban or apixaban and 48 hours for dabigatran. Keep in mind that dabigatran is eliminated exclusively through the kidney. So if you have a creatinine clearance less than 50, you need to increase that window to 4 days. For vitamin K antagonist, you need to have an INR of less than 2 for a radial approach, so the patient can be therapeutic, and less than 1.5 for femoral approach. It's very difficult to target to a certain INR. We manage an anticoagulation clinic, and we get a lot of requests of keep the patient between this level by this date, and it's not really mathematical, but we can proceed with an interruption and monitor the levels or use bridging if needed if the patient is high risk. For emergent procedures, using the radial axis is the way to go to the lower risk due to the lowest risk of bleeding. Doing the procedure, what would you do the day of the procedure with this patient? Proceed with the PCI without parenteral anticoagulant. I'm assuming that we stopped the anticoagulant because we were not in a rush to get it to the procedure. Start IV and fractionated heparin, start fondaparinux, or start IV argatroban for an INR target of 3. And most of you choose to start IV and fractionated heparin, and that's my recommendation. I would not proceed without a parenteral anticoagulant because remember, we stopped the anticoagulant. The patient no longer has anticoagulant effect, so we will need to provide it parenterally. So start IV and fractionated heparin will be my choice. Fondaparinux, we don't use it for PCI due to the risk of thrombosis of the catheter. So during the procedure, there's no changes in what we do. The patients will not be on anticoagulant at the time, will be only on parenteral anticoagulation. So this will not change from what we saw in the first slides of the talk. And now we're going to focus on what to do after the procedure. So this is the patient. He had the coronary angiogram. This is the pre-existing stent, area of stenosis and a thrombus, and a distal occlusion, and he had 3 new stents. How long would you continue triple therapy on him? We know he needs to continue on anticoagulation because he had a recent DVT and PE less than 3 months ago. It was actually 2 months ago. He had multiple stents. Well, how long would you continue triple therapy? Less than 1 week, 1 to 4 weeks, 12 weeks, 12 months, or lifelong. And most of you choose between less than 1 week and between 1 week and 4 weeks. Both are good options. We try to keep it to a minimum. If we can keep it to less than a month, it will be better. And then the next question was what to do regarding anticoagulation. The options were to continue with the dabigatran. That's what he was on before. Continue with dabigatran to bridge him to warfarin, switch to apixaban, or discontinue anticoagulation. And if you remember the case, he had a creatinine of 1.6. He had a creatinine clearance of less than 50. And at the beginning, when we saw the patient initially, so we're not going to do the poll because I gave up the answer. And the answer is to, yes, 100% switch to apixaban. And this is just to bring you back what are as a reminder, the risk of bleeding and thrombosis and ischemia of the stent to keep into consideration. There's a recommendation, as Dr. Elide show, of using DOACs after PCI over warfarin. There were multiple studies like the Pioneer, Redual PCI, Augustus trial, and Trust, and they all show consistently that DOACs have less bleeding than vitamin K antagonist, and they all also show consistently that triple therapy has more bleeding than double therapy. So the recommendation is to keep the patient in a DOAC if they're already on a DOAC, so I don't see a reason to transition the patient to warfarin unless that's our only choice, and also to try to limit the triple therapy to a minimum. And when we talk about antiplatelets, you also discussed this briefly in the previous talk, that prasugrel compared to clopidogrel, clopidogrel has had a higher risk of bleeding, similar reduction in events, and the same happened with ticagrelor. So although we don't have a lot of studies combining DOACs with prasugrel and ticagrelor, extrapolating from the studies that compare the use of clopidogrel with prasugrel and ticagrelor, and knowing that clopidogrel consistently show lower bleeding risk than both prasugrel or ticagrelor, we prefer clopidogrel for patients that need to be on anticoagulation. Regarding aspirin, recommendations are to keep during hospitalization. Consider extending for up to 30 days, that we saw in the question, in patients that have a very high risk of in-stent thrombosis and have a low bleeding risk. Otherwise, we keep it to a minimum just during hospitalization, or even lower than a week. In patients that are on a vitamin K antagonist, we will go over what would be those indications. We keep the aspirin until the INR is therapeutic. So after PCI, patients requiring anticoagulation, we will keep them on clopidogrel and oral anticoagulant, and then transition to aspirin and oral anticoagulant, or clopidogrel and oral anticoagulant up to the 12-month mark, and then they will be continued on just oral anticoagulants if they have a persistent indication. That's the general recommendations for patients with an average risk. If you have a patient with a very high bleeding risk, you're going to try to limit the time that they're going to be on both on clopidogrel and oral anticoagulants. So for stable disease, you're going to do it for a month to 3 months. And for acute coronary syndrome, you're going to keep the clopidogrel for 6 months and then just continue with anticoagulants. Remember, this is for patients that you're very concerned about bleeding risk, have a bleeding risk higher than average. For patients with a very high thrombotic risk, these are the patients that we're going to consider having triple therapy, even for a short period of time, shortly after the procedure, definitely less than a month. And they're going to be on dual antiplatelet and anticoagulant, so a single antiplatelet and an oral anticoagulant for 12 months or even beyond that, and it will be clopidogrel and oral anticoagulant, or you could transition to aspirin in patients with stable ischemic heart disease, recommended to stay on the clopidogrel for longer if they have acute coronary syndrome. General rules: individualize the plan for your patients. Take into consideration the bleeding risk, the thrombotic risk, and whether this is an acute event or stable heart disease. Keep triple therapy to a minimum, inpatient only to a maximum of 30 days in patients with a very high thrombotic risk, especially if it's a stent thrombosis risk. If you need to use aspirin, use the lowest dose, which is 100 milligrams. Prefer clopidogrel over P2Y12 in other P2Y12s like prasugrel or ticagrelor, and DOACs over vitamin K antagonist if it's possible because of the indication. How we choose a DOAC: if we have a patient that needs to be on one, we have to take into consideration absorption, metabolism, clearance, and medication interactions. And finally, a lot of patients have to choose based on cost. If we take into consideration clearance, remember that dabigatran has the highest renal excretion, so patients with renal disease will have a possibility of having higher bleeding risk and accumulating levels of dabigatran in the system. Apixaban is the one that has the lowest renal metabolism but has a significant hepatic metabolism. So in a patient with liver failure, that will not be your preferred DOAC. Most DOACs have dose reductions if the indication is atrial fibrillation. There's no dose reduction approved for treatment of VTE. And there's a dose reduction of apixaban you can treat with 2.5 if you have two of these risk factors: age, body weight, or creatinine. And there's a dose reduction of dabigatran, edoxaban, and rivaroxaban, all based on creatinine clearance. Remember, this is not GFR, this is creatinine clearance, and both numbers can be different. For venous thromboembolism, remember that not all the patients need to be on lifelong anticoagulation, and not everybody needs to be on therapeutic anticoagulation long term. So some of the patients can have their dose of anticoagulant reduced or discontinued, and that will also reduce your risk of bleeding and will allow you to be safely using antiplatelets. So high-risk thrombophilia, such as protein C, protein S, antithrombin deficiency, and antiphospholipid syndrome, they need lifelong anticoagulation. If you have a patient with active cancer, they also need anticoagulation as long as the cancer is active if the clot was caused by the cancer. And if you have an unprovoked thrombus, it's an individualized decision. So, and you have to decide with the patient what were the risks at the time and what are the benefits of continuing a preventive therapy versus discontinuing anticoagulants. And two of our DOACs, rivaroxaban and apixaban, have a low dose approved for long-term prophylaxis. So a patient with an unprovoked VTE after 6 months of anticoagulation could be transitioned to rivaroxaban 10 or apixaban 2.5 twice a day. That has a lower bleeding risk. Bleeding risk is comparable to being on a low dose of aspirin, lower than the therapeutic anticoagulation. And that's something to keep in mind if you have a patient that needs to be on both anticoagulants and antiplatelets. For cancer-associated thrombosis, low molecular weight heparin and DOACs are preferred over vitamin K antagonist. And in some type of cancer, such as GI bleeding, a low molecular weight heparin may have a lower bleeding risk than DOACs. There's still indications in which we have to use vitamin K antagonist as much as we like the convenience of DOACs. Remember, mechanical valves, moderate to severe mitral stenosis, antiphospholipid syndrome, LV thrombus, severe renal disease with a creatinine clearance of less than 30, peripheral bypasses, and obesity, and an acute VTE because the levels of DOACs can be unpredictable. So those patients, unfortunately, will need to stay on a vitamin K antagonist and not be transitioned to a DOAC despite a PCI. Things that you can do to reduce the risk of bleeding is to recommend frequent monitoring. So instead of spacing it out to 4 to 6 weeks, try to keep the patients on a closer monitoring routine and try to keep them at the lower end of the therapeutic range. I don't recommend narrowing the therapeutic range because that tends to the patients being all over the place, bouncing above and below. So keep them between 2 and 3 or 2.5 and 3.5, but try to keep them on the lower end. Some vitamin K antagonist pearls. Remember that to keep a patient on aspirin until the warfarin is therapeutic if the patient's had a PCI. And bridging with parenteral anticoagulants, bridging for heparin, it's indicated only if you have a very high risk of thromboembolism. Otherwise, you are increasing the risk of bleeding. So if you have a left atrial or ventricular thrombus, if patients had an ischemic stroke or systemic embolization within the last year, or if they have a high-risk mechanical valve, they will need to be bridged. Otherwise, you just discontinue warfarin for the procedure and then resume afterwards. No bridging required. When we resume anticoagulation after PCI, we need to make sure that we have adequate hemostasis, and that can be helped with a closure device or radial approach, and we're going to hear more about that in the next talk. DOACs, remember, they don't require bridging ever. The half-life of a DOAC is very similar to low molecular weight heparin, so when we're bridging, we're just duplicating an anticoagulant, putting the patient at risk of bleeding. And vitamin K rarely requires bridging, only for very high risk. Other things that we can do to minimize the bleeding risk, besides what we're going to talk, what you're going to hear in the next talk, focus on reviewing the medication list, avoid any unnecessary medications. Remember that although we are very familiar with interactions with warfarin, there's also a lot of interactions with DOACs, and I have a table coming up with the most common cardiac medications and DOAC interactions. Try to discontinue all medications that are not necessary and increase the bleeding risk. Keep in mind that some supplements such as vitamin E, fish oil, Jingo, they all increase bleeding risk. So if you're putting your patient on an antiplatelet and an anticoagulant, and on top of that they're on supplements, you're increasing the risk of bleeding. Consider using a PPI or H2 antagonist in patients with a history of gastric bleeding. These are some of the common medications used in cardiology that will have interactions with dabigatran, with all of the DOACs, or with just rivaroxaban and apixaban, and will increase the bleeding risk. So take-home points. PCI requires anticoagulation for the procedure, and thrombolytics require anticoagulation afterwards. In patients with chronic anticoagulation, the indication for anticoagulation, the risk of bleeding, and the risk of thrombosis need to be assessed at the time of the PCI and periodically to minimize the risk and to adjust the medication regime to the current situation of the patient. And also consider factors influencing the risk of bleeding, such as medication interactions or supplements, things that you can do to minimize the risk of the patients. Keep triple therapy to a minimum and use a low dose of aspirin. Choose clopidogrel over prasugrel or ticagrelor. Use DOACs, prefer DOACs over vitamin K antagonist if appropriate. Use the lowest approved dose for the indication. So remember, if you use atrial fibrillation, you can do dose adjustments based on age or renal failure. If it's VTE, you can lower the dose after the initial 6 months. And use the low end of the therapeutic range for vitamin K antagonist and frequent monitoring.